Welcome to PharmaBliz channel. I'm Dr. Jayashri going to discuss about pharmacokinetics distribution of drugs in body.
Now let's see about definition of distribution. Once a drug has entered into the bloodstream, it gets distributed to other tissues. It should cross several barriers before reaching the site of action. It involves the transport mechanism such as filtration, diffusion, and specialized transport. The extent of distribution of a drug depends on its lipid solubility, ionization at physiological pH, extent of binding to plasma and tissue proteins, presence of tissue-specific transporters, differences in regional blood flow. Next, about redistribution. Highly lipid-soluble drugs get initially distributed to organs with high blood flow, brain, heart, kidney, etc. But later, it gets distributed to less vascular tissues such as muscle and fat, plasma concentration falls, and the drug is withdrawn from the highly perfused sites. For example, anesthetic action of thiopentone sodium, injected IV, induces anesthesia in 10 to 20 seconds, but the effect ceases in 5 to 15 minutes due to redistribution. We will see about the drugs that highly bound to plasma proteins such as albumin and alpha-glycoprotein. The drugs that bind to albumin involves barbiturates, benzodiazepines, valproic acid, phenytoin, penicillins, sulfonamides, tolbutamide, tetracyclines. The drugs that bind to alpha-glycoprotein involves beta blockers, bupivacaine, lidocaine, disopyramide, imipramine, methadone, prazosin, verapamil, quinidine.
Various barriers of drug distribution include blood-brain barrier and blood-CSF barrier. In blood-brain barrier, the capillary endothelial cells in brain have tight junctions and lack large paracellular spaces. The glial cells envelope the capillaries, and together these form the blood-brain barrier. In blood-CSF barrier, similarly, blood-CSF barrier is located in the choroid plexus, and capillaries are lined by choroidal epithelium having tight junctions. Both these barriers are lipoidal in nature and limit the entry of non-lipid soluble drugs. Examples include streptomycin, neostigmine. Therefore, only lipid-soluble drugs are able to penetrate and have action on the central nervous system. Additionally, efflux transporters like P-glycoprotein and anion transporter are present in brain and choroidal vessels. They extrude many drugs that enter brain by other processes and serve to augment the protective barrier against potentially harmful xenobiotics. For example, dopamine does not enter brain, but its precursor levodopa, which is used in Parkinsonism. Inflammation of meninges or brain increases permeability of these barriers. BBB is deficient at the CTZ in the medulla oblongata and at certain periventricular sites. We will look into passage of drugs across placenta, lipid-soluble. Unionized drugs readily cross the placenta, while lipid-insoluble drugs cross to a much lesser extent. The placental efflux P-glycoprotein and other transporters like BCRP, MRP3 also serve to limit fetal exposure to maternally administered drugs. Placenta is a site for drug metabolism also, which may lower or modify exposure of the fetus to the administered drug. Thus, it is an incomplete barrier, and almost any drug taken by the mother can affect the fetus or the newborn. For example, morphine. Next important criteria in drug distribution is plasma protein binding. On reaching the circulation, most drugs bind to plasma proteins. Acidic drugs generally binds to plasma albumin, and basic drugs binds to alpha-1 acid glycoprotein. The free or unbound fraction of the drug is only available for action, metabolism, and excretion, while the protein-bound form serves as a reservoir. The extent of protein binding varies with each drug. For example, warfarin is 99%, and morphine is 35% protein bound. Clinical significance of plasma protein. Binding protein-bound drug does not cross membranes. The bound fraction is not available for action. When the free drug levels in the plasma fall, bound drug is released. Thus, protein binding serves as temporary storage of the drug. High degree of protein binding generally makes the drug long-acting because bound fraction is not available for metabolism or excretion. One drug can bind to many sites on the albumin molecule. Conversely, more than one drug can bind to the same site. This can give rise to displacement interactions among drugs bound to the same site. For example, warfarin is 99% bound to albumin, and free fraction is 1%. If another drug, indomethacin, is administered subsequently, it reduces its binding to 95%. The free form then becomes 5%. Chronic renal failure and chronic liver disease result in hypoalbuminemia, with reduced protein binding of drugs, leading to raised levels of free drug. Example of drugs for such criteria includes phenytoin and furosemide. In-tissue storage drugs may also accumulate in specific organs by active transport or get bound to specific tissue constituents. Drugs sequestrated in various tissues are unequally distributed, tend to have larger volume of distribution and longer duration of action. Some may exert local toxicity due to high concentration. Example, tetracyclines on bone and teeth, chloroquine on retina, streptomycin on vestibular apparatus, emetine on heart and skeletal muscle. Drugs may also selectively bind to specific intracellular organelle. Example, tetracycline to mitochondria, chloroquine to nuclei. Thanks for watching.